2012 for the indication of age-related macular degeneration, choroidal neovascular membrane. And today we have reached to over more than 53 million doses given since the launch. More than 7.7 million patient year exposure. As of September 21, 2012, the VEGF trap, aflibercept ophthalmic injection, recommended for approval for the treatment of wet age-related macular degeneration. And since then, we have approval for all the indications, including CRVO, which was approved in 2013, DME 2014, and then myopic CNV and branch retinal vein 2015. And with that, through multiple studies that we can see in neovascular AMD, we have the VIEW 1, VIEW 2, and SIGHT, and it is approved now in almost 109 countries. We have for DME, starting from the Da Vinci, then the Vivid, Vista, and Vivid East, approved for DME in 104 countries. RVO, we have the Copernicus and the Galileo, then the Vibrant. This is approved for CRVO in 106 countries and 103 countries for branch retinal vein occlusion. And we have the MIRROR study for the myopic CNV. And it is approved for myopic CNV in almost 100 countries. It is approved for 5 indications in 3 years, over 7.7 million patient year exposure, more than 53 million vials distributed since the launch. Now we have the present. The present is more depending upon the real-world evidence. And we have almost now over 20 studies in 20 countries, including the REALM, the study for the myopic CNV. We have the Aquila, REAL, Draco, Apollon, and we have from the Middle East as well one study, which is the Auriga study for DME and retinal vein occlusion, including almost 2,550 patients. We have multiple studies from the Middle East and from Asia, from Japan, from India. All of these studies are using the EYLEA for various indications. The international guidelines have recommended the use of aflibercept in patients with best-corrected visual acuity of less than 69 letters for the patients of DME. Aflibercept is the drug of choice in DME in eyes with baseline best-corrected visual acuity below 69 letters, ETDRS score, as it shows superiority to bevacizumab and ranibizumab over 2 years. In patients with more or worse visual acuity, aflibercept may result in more rapid visual acuity improvement, more than ranibizumab over 1 year, and actually in further studies with ranibizumab 0.5, it has shown superiority as well, as we can see in this real-world evidence with baseline visual acuity less than 69 letters, achieved significantly greater visual acuity gain with aflibercept rather than ranibizumab at year 1, over more than 5.1 letters. In this early intensive treatment by proactive treat and extend, aflibercept allows for improvement of and maintenance of visual acuity with reduced treatment burden in DME. These are very important studies we can see in JADE, VIBIM, and HIRANO. We reach to actually 89, almost 90% of our patients at year 1 can reach to 12-week interval, while in VIBIM we can reach to 75% of our patients to be extended to 12 weeks every 3 months, while in HIRANO we can reach to almost 66% of patients to up to 4 months, so 16 weeks interval of injection free for our patients. And this is actually great because this is with aflibercept 2 milligram. I will show briefly some of my cases. This is a 56 years old female patient, hypertensive, diabetic for almost 18 years. The hemoglobin A1C is 8.1. For our region, it is almost as if it is controlled. The visual acuity at presentation was 2150, 2200 in the left eye, nuclear sclerosis, and severe NPDR. This is the image for the right eye, and intraretinal and subretinal fluid, some hard exudates, as you can see. With starting of the aflibercept, this is 1 week after the injection, and usually I prefer to see those patients just 1 week after the first injection to see how things are improving and to give confidence for those patients, because usually when you are talking to the patient, just explaining about the injections and how many injections we are giving, we want to show them that actually this drug is working, and it is working as early as possible, and we can see that here. This is actually after the first injection, and we can see actually a marked improvement in the OCT image and improvement in the visual acuity as well. This continued with monthly injection until stability, and we reached stability actually after 3 injections. So although the indication is 5 loading dose, but usually when things go back to normal, I start to extend my treatment. And we can reach with that to, in this case, actually, she improved, and we are now monitoring the patient, and she now on 4-month interval, and everything is stable. She returned back to normal, visual acuity to 22, which is excellent for both eyes. This is another patient, 47 years old, male patient, hyperlipidemic for when discovered 2 years, discovered diabetes since 2 years, and hemoglobin A1C now is 9.2. It is definitely, this patient is not compliant with the treatment. The visual acuity at presentation, 2100 in the right eye, 2070 minus in the left eye, clear lens, and severe NPDR. So this is a patient discovered 2 years back, and we can see this extensive hard exudates in both eyes and severe NPDR. This is the image at presentation for both eyes, 540 for the right eye, 490 for the left eye, intraretinal and subretinal fluid, extensive exudation, as you can see here in the photos. So in such patients, we need something which is very potent to give this patient reliability, because this patient, I would know that he will not be compliant for the treatment if I will not give him something that will solve his problem as early as possible. And that's what happened with when given Eylea. This is the image after 1 week from the first injection. In both eyes, the drop in the central subfield thickness 410 microns, 355 microns in the left eye. And this maintained, but as what I was expecting, this patient disappeared for 1 month. So given 1 injection, disappeared for 1 month, and then returned back again and started the treatment, and now all the edema is gone, the hard exudates is improving, and this is the final picture when he was last seen, I think 3 months back, and the patient as well disappeared. But despite that, you can see even that the hard exudates is disappearing. We do not need steroids for such patient. We can give very potent anti-VEGF that can reduce the central subfield thickness and decrease the hard exudates at the same time. So aflibercept provides potential for extended treatment intervals up to 16 weeks in patients with neovascular AMD and in patients with DME, as we have just shown. This is a patient with choroidal neovascular membrane. This is a 59 years old male patient, hypertensive for over 8 years, heavy smoker. The vision is 20/30 in the right eye, and sudden drop of vision in the left eye. It dropped to 2400. He has some nuclear sclerosis, but that's not the issue. This patient actually presented to me after given an injection of anti-VEGF elsewhere, and he was complaining of that he did not improve as he's expecting. I explained to him that the anti-VEGF treatment is the treatment of choice, and in his condition, I would rather use Eylea to give him the best possible drying effect. This is after just 1 week. As we can see, the fluid, the subretinal fluid started to improve. Even the SHREM, or the choroidal neovascular membrane, started to shrink, and the patient was extremely happy. We continued the treatment. This is on monthly basis. The fluid is totally gone. The choroidal neovascular membrane shrinked, and the vision improved to 20/70, then continued to improve to 20/50. This is the last, I think this is the last image, maybe, no, this one. So although you can see if you can compare the choroidal neovascular membrane and the extent of it at the start of the treatment, and now with this treatment, now the vision is improved to 20/40. The patient is very happy. We are starting to extend the treatment. Now he's reaching to almost 3 months interval with maintaining of the vision and maintaining the improvement in the anatomical and the visual improvement. I'll move very quickly to the last case of mine so that we can have some discussion. This is a patient, he did ICL in both eyes 2 years back. He's 39 years, Japanese patient, high myope. The visual acuity 20/20 in the right eye because of the ICL, and the left eye dropped to 2100. Clear lens, the ICL well in place, and this is the image at presentation. So you can see this extensive edema and hemorrhage encroaching on the fovea. The central part was not that involved. So at the presentation, I decided for him that we need to give an injection as soon as possible to maintain the vision and to help to improve the vision. Sorry, I think I missed some slide. But anyway, the edema started to subside immediately after one injection, and some hard exudates was there, and some intraretinal hemorrhage, and the intraretinal fluid was still there, but with repeated injection, till stability. Now